Hi everyone. My PhD thesis title is The Effect of Oral Contraceptives on Metabolic Balance. My name is Árpád Jankó. I am a PhD student and starting as a resident doctor at the gynecology clinic from September. I have two projects at the moment. Both of them are systematic reviews and meta-analyses. The title of my first project is investigating the effect of oral contraceptives on metabolic balance, on a carbohydrate metabolism. As I said, this is a systematic review and meta-analysis. A short background about my topic. Oral contraceptives are one of the most commonly used forms of contraception. Over 70 million people use it globally. They're so popular because they're effective and they also have non-contraceptive benefits as reducing acne and dysmenorrhea. As every drug, this also has side effects, and besides their well-known adverse effects, it's suspected that they can cause alterations in carbohydrate metabolism, so they could decrease glucose tolerance and increase insulin resistance, which could be risk factors for type 2 diabetes and cardiovascular disease. There are no conclusive guidelines in the matter, so we aim to assess the effect of these drugs on carbohydrate metabolism. We used the PICO framework. Our population was OC users, and we conducted a before and after comparison. And our main outcome was the oral glucose tolerance test. We had 15,000 results in 3 different databases, and eventually 116 full texts. So this is a short explanation going on to the next slides. We had too many compounds to include into the analysis, so we decided that drugs with similar chemical structure behave alike. So we created 4 groups based on these chemical structures. For example, the 19 nortestosterone derivatives of the gonads, etc. So these will be the names that I'm going to be referencing in future slides. So this is my first diagram. It's a bit more complicated than a basic forest plot. On the right-hand side, it's just a data visualization for better understanding. This looked at a healthy population, and because we had too many variables, we created 4 subgroups. As I said, the different colors represented the different types of drugs, and also having every time frame in the OGTT test separately would have given us too much data to put into the model. So we created 4 subgroups: a fasting category, a early category, which is 45 minutes and below on the OGTT test, a peak category, which is 60 minutes at the OGTT test, and a late category, which is 90 minutes and over on the OGTT test. So without getting into too much detail on this diagram, the colors represent the different types of compounds. The shapes, the circles represent monophasic drugs, and the triangles represent triphasic drugs. And without going into too much detail again, we can see that monophasic and triphasic drugs both, there isn't really a difference in the two. Maybe triphasic drugs elevate blood glucose a little bit more. And we can also see that different drugs behave differently, except for drospirenone, which has a neutral effect on blood glucose levels. All other types of compounds elevate blood glucose levels in the different time periods. We also looked at a PCOS subgroup. Looking at this diagram, We only had monophasic compounds, so no triphasic ones, and the change in blood glucose was even opposite. So at drospirenone, the red dot, we can see a almost 2 millimolar per liter decrease in the late phase, while the other compounds, pregnanes elevate blood glucose, while the gonanes have a neutral effect on them. So we also looked at the insulin levels. These remained the same almost. So this could have a couple of reasons. For example, these drugs could affect insulin levels. Well, they could affect insulin sensitivity, which resulted in the changes in blood glucose previously. We also looked at SHBG in healthy patients and in PCOS patients, where all of our results came out as significant. So they elevated SHBG. The strengths of our study is that while it's been suspected that oral contraceptives have an effect on carbohydrate metabolism, us creating these compound-specific categories based on chemical structure allows us to examine them individually and compare them to each other. So this is something that hasn't really been done before. And our statistical model is also a multi-level, multi-variable, quite complicated model, which gives it strength. Our limitations could be that these populations were diverse and fragmented, and we also included non-randomized studies. So our conclusion would be that oral contraceptive groups affect blood glucose levels, with the exception of drospirenone, which has a neutral effect. And when examining a higher risk population, so patients that have PCOS, we also observe similar results, while drospirenone could even potentially enhance the blood glucose profile. So this is where I am in my manuscript. And my second project is quite similar. It's investigating lipid metabolism. Instead of carbohydrate parameters, we're going to look at triglycerides, LDL, HDL, which could be risk factors for coronary heart disease. And to summarize, I have two projects at the moment, both of them systematic reviews and meta-analyses, and thank you for your attention. As Kobe Bryant said, if you're afraid to fail, then you're probably going to fail.
Congratulations to a very nice presentation. I got one question regarding the first forest plot. The difference was like 0.5 millimole of glucose. Do you consider this to be a clinically relevant change?
It could be significant. This OGTT test, opposed to a fasting blood glucose measurement, which is a static value, this dynamic test can give us more subtle information and changes that can occur before we see any differences in the values in fasting blood glucose. So this half millimole per liter difference, I can't exactly say if it's clinically relevant, but it could be something to look at in the future and maybe conduct more prospective studies about.
And I got one more question regarding your last outcomes about SABG. Can you explain to me, because I am not in the field, how it's clinically relevant and the change of the concept?
Yes, we also included this outcome because oral contraceptives elevate SHBG, and this has been proven in the past. So that's why I didn't go into too much detail, because this is kind of a fact. So in patients who have PCOS, for example, they have androgenic symptoms, and lowering elevating SHBG could alleviate their symptoms and be helpful for their treatment.
I would like to ask you about the length of use.
Yes.
Was there any data about whether there was a difference if the patients were using it for, I don't know, 10 years, 2 years, or 2 months?
Yes, this analysis that we did is quite short term. So every study that we examined are 12 months or sooner.
Thank you, Arby. One of your limitations was that you included non-randomized studies, but were there actually some randomized studies in the...
Yes, about 70% of the studies are RCTs, and we also included studies that are also clinical trials, but the patient groups weren't randomized.
Okay, and did you make a subgroup analysis based on study design, randomized clinical trials versus non-RCTs?
I don't think so, no. So
I think it's worth doing. We always do a subgroup analysis for RCTs only, and we see, like you make one subgroup with and without, and you can see the overall as well. So maybe it's worth discussing with the team. And why do you think drospirenone was not affecting the glucose levels? Like, what's the pathomechanism?
Well, these different kinds of oral contraceptives, based on their chemical structure, they have different properties. For example, one of them is more androgenic than the other. Drospirenone, for example, is a mineralocorticoid derivative, so it's a bit different chemically as the others. So maybe this is the reason that it's a bit different.
Thank you so much.